So this morning, it is my distinct pleasure to introduce our Grand Round speaker, Dr. Michelle Morrill, who will be discussing comprehensive gender-affirming surgical care. Dr. Morrill is a urogynecologist and reconstructive pelvic surgeon at Kaiser Permanente San Francisco, where she's an integral member of the multidisciplinary gender-affirming surgery team. Dr. Morrill completed her fellowship in urogynecology at UC San Diego following her OBGYN residency at Thomas Jefferson. Dr. Morrill currently serves as a surgical quality lead and the physician co-chair for highly reliable surgical team committee at Kaiser. She has held numerous editorial roles, including currently the associate editor for urogynecology and a member of the Society of Gynecologic Surgeons Publications Review Committee. Dr. Morrill is passionate about providing evidence-based care for transgender individuals and has given numerous national presentations on gender-affirming surgical care. Please join me in welcoming Dr. Michelle Morrill.
Thank you very much. Excuse me. So first of all, just quick disclosures, although I have no industry associations, obviously I work at Kaiser and have my own work in gender-affirming surgery to sort of drive me on this. What I'm going to be talking to you about today, number one, I'm going to broadly review the organization of our multidisciplinary approach at Kaiser Northern California for caring for our transgender patients. I'm going to then discuss some considerations and options for gender-affirming surgery for people assigned female at birth. So that's where my specialty is. I realize that I am leaving out half of the population, and for that, I would certainly refer you to other people whose specialty is there. And then finally, I'm going to review some possible complications associated with the gender-affirming surgeries that I participate in. First, I do want to orient you to the Standards of Care version 8. So this is put out by the World Professional Association for Healthcare, for Transgender Healthcare, or WPATH. And they produced their version 8 just a couple of years ago. The purpose of this, and this is stated within the SOC, is to provide clinical guidance for health professionals in overall all care that might be given to transgender or gender diverse people. And I do want to highlight that it is a 259-page piece of document. So I do recommend taking a look at this. If you're involved in any care for transgender patients, realize that you might skim some parts. All right, I am going to pull out a few what I think are really important guidelines that the SOC 8 contains. Number one, they really highlight that transgender and gender diverse people have differing needs. I'll be talking a little bit about that here today, but whenever you're approaching a patient who is transgender, realize that you have no idea what they actually are looking for in order to receive the health care that they need. Also, that the SOC 8 made some very significant revisions to what they've recommended in the past in the SOC 7 and prior versions of that, mainly in order to remove unnecessary barriers to care. So I want to highlight this particular statement that they recommend, and that underline is my own emphasis, a single opinion for initiation of treatment. So I think a lot of people are familiar with that old recommendation that there be 2 letters provided before anybody is allowed to go under gender-affirming surgery. And they really want to pull back on that. They are not using the word letters. That letter alone was difficult for some people to be able to get, and they just want to have one appropriate provider review this patient in order to assess them for the gender-affirming care that they want to receive. A couple of other things just to highlight that you'll find in the SOC. First of all, they give some very specific qualifications and competencies for people who are going to be caring for the transgender and gender diverse patients. I do want to say that they say that patients should have marked and sustained gender incongruence, but they don't put any time period on that. I thought that was kind of interesting to say marked and sustained, but not really defining what time period sustained means. In previous versions, you'll find things like needs to have done this for a year or that for a certain period of time. They really backed away from that. They do emphasize the importance of assessing not just whether or not this person is uncomfortable with their gender, but also their mental health, their psychosocial concerns, their capacity for consent. All of those are a part of the assessment before starting care for any transgender person. And then finally, this was one of the very few times where they did pull out a time recommendation, and that was the capacity to understand a treatment effect on fertility. The person really should have been on hormone therapy for 6 months at that point. That's why I pulled that out as like the one time length of time that I found in the SOC 8. So overall, the intention of these guidelines is to be flexible, but to give guidelines in terms of how we're supposed to approach care for transgender patients. And they highlight that any departures from their guidelines should be recognized. They're not saying that that's wrong, but need to be discussed and documented in order to move forward with appropriate care. All right, so I've given you a grounding in the SOC 8. Now I'm going to just broadly describe what we do in Kaiser, Northern California for caring for our transgender patients. So first of all, you probably are aware, Northern California Kaiser is spread around Northern California. So we go up to Santa Rosa, down to San Jose, out to Sacramento, out to Fresno. You'll find facilities all over the place, and every one of those is really expected to provide this care that's at the bottom that you see. Sorry, my cursor moves really fast. You'll find that just general care, anybody should be able to get the care that they want: primary care, gynecologic care, behavioral health. All of those should be available at their local facility. But we do have sub-regional specialty areas where people might have dedicated clinics with multidisciplinary services, so they can see multiple different types of professionals at that one facility. Transition-related mental health care, hormone initiation, gynecologic care, all in a single clinic that is gender neutral, which is something that some patients really prefer to be able to approach. Also, some of our less complex surgical procedures are available throughout the region. So top surgeries, facial feminization, basically that's what I've got summarized there. So all of those are available at a number of places around the region. And then finally, we have a single site where we have our surgical center of excellence, where we really perform all of our bottom surgeries. Bottom surgery, I'm referring to any reconstruction of the genitals. And that's what we have here in Kaiser, San Francisco. Something that we're really proud of is spreading the importance of cultural agility or awareness throughout all of our staff. That means that our doctors, our nurses, and also our environmental services people all get training on how to appropriately interact with somebody who is not gender conforming. I really want to emphasize that that is something that we find is important for our patients' care. We've had missteps, and I've had patients tell me that they didn't like the way that they were spoken to by somebody that they interacted with, and we get on that immediately. We want to make sure that we're coaching everybody in our facilities to interact with our patients appropriately. All right. So some unique considerations for care within our Kaiser system. And really, I'm kind of highlighting these because it makes our lives a lot easier, I think, than outside of the Kaiser system. So first of all, as you probably know, we have a combined insurance and healthcare system. Essentially, what that means is that I never need to ask an insurance company whether or not I can perform a certain type of care for my patients. They just leave that up to the doctors. Also, we have an electronic medical record system. I know everybody has that, but really that means that every provider within our system is on the same system, and we can communicate pretty much immediately. Of course, that means that we can communicate with primary care providers far away very quickly, but also it means that testing can be assessed very quickly too. I find this just makes our lives so easy. And also we have this standardized referral process. So you saw that pyramid that I presented earlier. We have this very standardized approach to making sure that everybody is getting the care that they want. So specifically, you go through a specific preoperative assessment. We can coordinate our surgeons to get everybody into the operating room at the same time very easily because we're all under one roof. The postoperative follow-up means that although, of course, we do want our patients to come back into our clinic for some of their postoperative assessments, they don't have to come and see us for everything. When they do have any sort of an urgent situation or they end up in an emergency room in another facility, those emergency room doctors can easily reach out to us if they have any questions. And then I wanted to highlight, just because we have published on this, our postoperative assessment. This is, I just think, a great example of what we can do. We started out when we first did these surgeries, having every patient do a VCUG to assess the patency of their neourethra. You'll hear more about this shortly. Using that VCUG training that we did within Kaiser San Francisco, we learned pitfalls, things that we want to watch for in that imaging. We then went out into multiple facilities around the region, trained the radiologist there to be able to do the same assessments that we were doing in San Francisco. And because of that electronic medical record, the moment that that assessment is done, that documentation is something that I or one of the other surgeons can review in order to decide whether this patient's urethra is fully healed or not. And overall, we have published on our those images in order to help other people with the same assessments. All right, so I've talked to you about what we do in Kaiser. Now I'm going to talk to you specifically about those surgeries for people assigned female at birth, the genital specific gender-affirming surgeries. So big picture, what we're talking about here is hysterectomy. And a question that might go along with that is whether or not we're going to remove one or both ovaries. We also perform vaginectomy. Now that might be a partial vaginectomy, basically what we call a colpocliosis in urogynecology, or a complete vaginectomy, meaning that we bring that closure down to the perineum. When we do that, it would require doing a urethral lengthening at that time, since we're closing the vagina down to the perineum. It's also really recommended if you're doing a urethral lengthening, and I'm going to show you some data about that shortly. Finally, then, I'm going to talk a little bit about metoidioplasty and phalloplasty. Since I'm not going to go into the details here about how to do the surgeries, I just really want to give you a broad overview of it. I just want to make sure people know metoidioplasty is where we do an external reconstruction to emphasize the usually enlarged clitoris, which has already been treated due to the testosterone that most of our patients are on. And we're able to just give that a little bit more length. Oftentimes, these surgeries might go along with a urethral lengthening, although not necessarily. These patients oftentimes want to have a scrotoplasty. Then going on to think about the phalloplasties. Phalloplasties involve using a flap of skin to create a phallus. Excuse me. For us, we oftentimes, the ways that we do it are either a radial forearm flap or using a flap from the anterolateral thigh. But there are other described techniques for creating a phallus. Along with that, may or may not get urethral lengthening, may or may not get a scrotoplasty. And then in terms of prostheses, for the phallus, they may or may not get prosthetics so that they can have penetrative intercourse. And they may or may not get testicular implants into the scrotum if they have one created. So many choices, people. So this is just a quick image to give you an idea of what I've gone over. First of all, on the picture on the left, should be familiar to everybody in this room. That's, of course, just native or cis female genitalia. Then looking into on the right side, we see the metoidioplasty, where we've done a vaginectomy and a hysterectomy and a urethral lengthening in this case, although again, not necessary for a metoidioplasty, where perhaps the person has the clitoris enlarged or released, and then maybe even a scrotum created, but they don't have to have the urethral lengthening. Phalloplasty is shown in the bottom right there, where a penis has been created. Again, sometimes people will just have the urethra brought to the base of the penis in order to decrease the risk of complications. And they're still able to oftentimes stand to urinate. All right. Quick epidemiology slide. Transgender and gender diverse persons are not terribly common. Here in the Bay Area, I think that we are really privileged to have a high number of patients who are coming here because of cultural acceptance and access to care. Overall, we see very small numbers. And of course, those differences in the numbers there, 0.45 versus 23.6 per 100,000, is affected by diagnosis criteria. But I do want to emphasize that not all transgender people seek surgical care. We know that about half of people who identify as transgender men or non-binary, assigned female at birth, will actually want to have a hysterectomy. For many of them, having a hysterectomy doesn't really help affirm their gender identity. Moving along to the metoidioplasty or phalloplasty, so really changing the external appearance, we see that about a third of those people will want to have those surgeries done, and even fewer are interested in having a vaginectomy. So these surgeries are not mandatory for gender affirmation. It's just something that really can help someone for whom this is a discomfort. There are a lot of significant considerations to these surgeries. Fertility, I think, is quite obvious, and we'll talk about that just a little bit more. Recovery time is significant. Now, from a hysterectomy, I think we're all familiar that that is not very long. The metoidioplasty, or the first stage of a phalloplasty, is very similar. The recovery time is just a matter of weeks. But for people who have a full phalloplasty, which involves a vascular pedicle and moving around and reconnecting very often major vessels, the recovery for that is in the term of months. And it can be really limiting. They have limited mobility during that time. There are a lot of complications. I'll show you a slide shortly that I think will be surprising to people, but the complication rates with these surgeries are very high. And then lastly is the scarring. Of course, for any reconstruction on the genitals like a metoidioplasty, you're going to end up with some level of scarring. But when we start talking about flaps, now we're talking about a big scar where a rectangle of skin has been removed from some part of that person's body. I'm not going to be able to describe every little detail of the possible considerations. So I did want to highlight this Dutch work, this work that's been done by this Dutch group. What I have in the example there on the left is just one small way that you can use their tool. They created this decision aid in order to consider the pros and cons of any aspect of the surgeries. They also have this for people assigned male at birth. And so I do encourage I encourage you to take a look at their website. All right, so now I'm going to start talking about some of those considerations. For hysterectomy and oophorectomy, obviously the big thing is to think about fertility. After a uterus is removed, you're not going to be able to carry a child, but oftentimes people will want to be able to have a child with their own genetic makeup. And so that is a conversation we have before any of these surgeries. Does that person want to have their eggs retrieved and frozen before we do an oophorectomy? Also, it is certainly possible that if they keep their ovaries and we do a hysterectomy and vaginectomy and everything else, they still might be able to have a retrieval done at a later time. All of those are conversations we want to have before we do anything that stops them from having options. Another thing to consider in removing somebody's ovaries is bone density protection. So most of the patients who come to see me for surgery are on testosterone, and that's going to be providing them the care that they need for bone density protection. But by keeping one or both ovaries, they're going to have that backup. And we really do present it to people, and I think it's understandable in this climate that there might be a time in the future where they aren't on testosterone, whether by their own choice or not. And that's something that I'm finding patients are more and more aware of. And so having that ovary as a backup is something that they're more comfortable with. If somebody, I guess I will say that there are a lot of patients I talk to who don't really feel like having ovaries messes with their gender identity. And they just say, you know, I want to have that backup, just leave those ovaries in there. That's fine. If somebody wants to have one ovary removed, I like to highlight this. We try and remove the ovary on the right. And the reason for that is that way, when they show up in an emergency with right lower quadrant pain, we're not worried about ovarian torsion. We can focus then on the API. Okay, so hysterectomy can be performed at the same time of these surgeries. That's actually what we try and do for anybody who wants this. Obviously, it makes the recovery time overall in their year or years less, because the recovery from the hysterectomy doesn't add to the time they have for the recovery from the vaginectomy, the urethral lengthening, metoidioplasty, or stage 1 phalloplasty that we're doing. I want to just briefly present our data, which I found very interesting. I want to highlight here that what we found when we first looked back at our first 3 years of doing these surgeries was that doing a hysterectomy at the time of the urethral lengthening surgery seemed to end up with lower rates of urethral problems. Why would doing a hysterectomy be protective for the urethra? Kind of scratched our heads for half a second, and then we realized, oh, we actually started doing those surgeries concomitantly, generally later on in our surgical experience. So what this actually highlighted was just our surgical experience. And as you can see, as we went through time there, we got better at what we were doing. Overall, my guess would be that doing a hysterectomy at the time of a surgery does not affect these outcomes. All right, now I'm going to talk about vaginectomy. This is really my primary role on the surgical team. It means really obliterating the vaginal canal. So I don't remove the vaginal tissue except for the lining on the inside of the vagina, the mucosa, and then just sew everything together in layers. You can kind of think about it as just a really aggressive colpocliesis, where instead of stopping at the urethrovesical junction, I'm removing all of the vaginal epithelium and bringing that closure down to the opening of the vagina. Excuse me. Now to talk about urethral lengthening. So I've already mentioned that people having a metoidioplasty or phalloplasty may choose to have a urethral lengthening or not. A lot of it has to do with the desire to stand to urinate. But also patients will frequently tell me they don't want a urethral lengthening because they don't want to have the complications that go along with it. And this one study that I have quoted here, they found that people were just generally happy with whichever route they choose, whether it's urethral lengthening or not. So why does it matter with vaginectomy? Well, when we do a urethral lengthening, I want to just highlight this spot here where the native urethral meatus gets attached to the neourethra that we create. The way that my team does it, and this is pretty common, is that we take the medial aspect of the labia minora and then tubularize that and attach it to the end of the native meatus. So there's a suture line along the entire ventral portion of the neourethra, and then of course the suture line attaching that neourethra to the native meatus. And those are where we might end up with complications. So pressurized urine flowing through there might be able to force a spot through and create a fistula. Or of course, while that healing is taking place, a scar might develop and form a stricture. A vaginectomy allows us to put layers of tissue over those attachment sites in order to minimize the risk of those complications, basically, in particular fistula. And this is the data that I mentioned earlier that talks about how very clearly doing a vaginectomy at the time of urethral lengthening decreases the risks. The two studies here that I have quoted were retrospective chart reviews, but over 200, in one case, almost 300 patients. And you can see the numbers there that by doing a vaginectomy, it more than halves the risk of developing any urethral complications or the development of a urethral fistula. So our practice is to not do a urethral lengthening without a vaginectomy. And I know that that is very common across the different teams around the world that do this. Excuse me. Just another couple of quick words about vaginectomy. The approach for that can be done either vaginally or laparoscopically. And the removal of the vaginal lining can be done either with sharp dissection. Some teams will actually use that dissected tissue in order to contribute to the urethral length. We tried that very briefly and then found that it was not very supportive, which of course made me as a urogynecologist go like, oh yeah, that's why I have a job. The lining of the vagina is supposed to be stretchy. That's what its job is. And it ends up not making a very good urethra. The other approach to removing that vaginal lining can be fulguration or burning of that tissue. Our own practice is not to do that. It seems like a bad idea to me. I looked and there's still no study comparing the two approaches, but I definitely found multiple expert opinions saying fulguration is not an appropriate way to do that vaginectomy. You're going to end up with more complications, mainly because you don't remove all of the vaginal mucosa. Here, talking about the two different approaches for the external reconstruction. The meta, as I mentioned before, is to release the clitoris, which is already enlarged in these patients to some extent. Certainly, some people have more of a response to testosterone than others. But incising either the suspensory ligament of the clitoris and or the clitoral vestibular septum in order to allow the clitoris to rise further away from the body. There are even more extensive procedures where people may release the crus of the clitoris from the pubic symphysis. That's not commonly performed, and generally just doing what is described in metoidioplasty will give an extra couple of centimeters of length. It's not a huge difference, but it's something. The phalloplasty, on the other hand, as I mentioned, is that creation of a phallus using a flap of the patient's skin, usually. The radial free forearm flap, we're able to double tube because there's not a lot of fat in the forearm, and that allows us to roll it on the outside to create the outside of the phallus, but then we create an inside roll that becomes the urethra. So for people who want a urethral lengthening, this usually is kind of the best way to do that. On the other hand, it ends up with a really obvious scar on the forearm, and that's something that a lot of patients want to avoid. So the ALT or anterior lateral thigh is the other approach that we use. A nice thing about that is that oftentimes we don't have to then reattach the vascular pedicle. We're able to just move the flap itself. It's not a free flap. The problem with the anterolateral thigh is, as you can imagine, most people have a pretty thick fat layer on that skin. And so we usually can only single tube it and then come back later in order to try and create a urethra inside that single tube. I listed here the latissimus dorsi as another source. We don't use this as a flap source, but it is another relatively common flap source. There are a lot of others that are described in the literature too, but these are the three certainly that are the most common. So how do these compare? Well, as you've heard, the metoidioplasty doesn't involve scarring outside the genital area and also can be done as a single stage. So most of our patients getting a metoidioplasty come in, have the surgery, go home the same day or the next day. Excuse me. There's also the possibility to perform a phalloplasty later. So there are very minimal differences between what we do for a metoidioplasty and what we do for our stage 1 phalloplasty. We always do our phalloplasty as a staged procedure. So somebody may elect to have a metoidioplasty now and then years later come back and have a phalloplasty. And we're happy to be able to do that. The phalloplasty, on the other hand, does allow for penetrative sex, requiring a prosthesis usually, and also the stand to void. Now, people with a metoidioplasty oftentimes can, to some extent, stand to void, but because the length of their phallus, being the clitoris in this case, really doesn't give them much projection away from their body. Basically, you can imagine kind of standing at a urinal, taking down your pants, but to get past your fly, you're gonna dribble on yourself, basically. So for that reason, the phalloplasty is really considered the standard procedure for somebody who wants to be able to stand to urinate. Other things that go along with the phalloplasty are the need for hair removal, obviously on that flap source. The time for recovery from this, as I mentioned, is months, and it's months during which there are really significant mobility restrictions in order to assure that the vascular attachments don't potentially get blocked off, and then we end up losing the flap. And there are an increased risk of complications with this longer, more involved, obviously, surgery. Other things I just briefly wanted to touch on, antibiotics for these procedures are generally what you would do for any sort of our hysterectomies or whatnot. So we use cephalexin, and then for any time that we get into the abdomen, so for instance, for a hysterectomy, we would add into that flagell. We are really conscientious of positioning. I find that even when we've done everything we can for positioning, sometimes with the second stage of our phalloplasties, since these guys have been just lying there still for generally 8+ hours, they're going to end up having some aches in their body. So we really want to make sure that we're positioning them carefully. All right, so I mentioned earlier that complication rate. So this is a systematic review and meta-analysis that was published just a couple of years ago, and it reported a 76% overall complication rate. Now, those complications include things like urinary tract infections, certainly things that I think we would all consider relatively minor, but still, that is a huge complication rate to think about when you're going into a surgery. Even more importantly, the rates of fistula formation or urethral stricture being almost 35% and 25% respectively, those are really big numbers. And I think that those are realistic numbers too. I found this interesting report where they actually sent out a survey to patients who'd had gender-affirming metoidioplasties and phalloplasties. It was an international study, so people having surgery all around the world. And they found almost the same numbers in terms of reported complications, which I found also interesting, especially since only about a third of patients who received the questionnaire responded to it. But also another thing they asked patients about was their mental health associated with those complications. And 20% of patients reported that that worsened their mental health. So it's a big deal when somebody decides to go through these surgeries, but then ends up with a complication. And we know that that's pretty common. All right. Vaginectomies can also specifically have complications. So this is something I feel like I can speak a little more to just because they're my surgeries. In the top surgery or top study that I have quoted there, what this group did was they looked back at 47 cases of transgender men who'd come to them needing stricture repair. So these were not just their own surgeries, it was patients coming from other sites who'd had these complications. And they found that almost 40% of them had some sort of a vaginal cavity remnant, which they presumed had something to do with this complication. This other study was a group that looked back just at their own surgeries. As you can see there, they did over 350 of these vaginectomies.
Third floor, postpartum,
Nobody here has to go good. And they found, they described these 3 patients who'd presented with a perineal swelling. To give the descriptions, it occurred years after the vaginectomy. Histologically, of course, they went in and removed these swellings, which they found on MRI were various sized collections. One was as big as 10 centimeters. And they removed those collections and the lining of them. Inside the collections, they described various types of fluid, green, purulent appearing, et cetera. But it was all the walls were squamous epithelium, really basically the lining of the vagina had regrown in those patients. And this is a group that you could tell from reading the paper, they pride themselves on that sharp dissection. They consider that very important. And then only one patient, I think that some people who aren't aware of the anatomy may think, oh, it's always going to be a Bartholin gland, but actually only one patient had this Bartholin gland that was seen in some of that tissue. And I'm going to just kind of step aside and say anecdotally, my own experience is really consistent with this. I mean, I think the numbers of vaginectomies that I've had, and I have had patients come back with collections inside, remnants of the vagina, despite all of my efforts to remove absolutely everything in there. I think that this is a very realistic report. All right. Other things I just like for people to think about in terms of complications with these surgeries: pelvic floor muscle spasm and pain. A lot of patients with that discomfort with their own genitalia have pelvic muscle spasm and pain. We work very closely with our own physical therapy department. I know other departments that do these surgeries actually require patients to go through physical therapy first, which I think is really key. Sadly, when I tried to find any information about this through Medline, I found nothing. So it's pure anecdotal, but I think it's very real. And then because I recently heard about this, the idea of what's the rate of regret? The rate of regret for having these surgeries is tiny. So from this one particular study where they sent out a survey to over 600 people who'd had masculinizing surgery, they found that 1% reported any regret about having had their surgeries. So I just want to offer that as a reassurance that regret is not a realistic thing to worry about being a big problem with these cases. So going back to what I said I was going to talk to you about today, I talked about the broad organization of how we do things in Kaiser, Northern California, and some unique abilities that we have within our system. Talked about considerations and options for gender-affirming surgeries as you approach a patient who does want these surgeries. And then lastly, we talked about some of those complications, which unfortunately are very common for these surgeries. And I'm happy to answer any questions. And I understand there's a Zoom also in case anybody has any questions. Yes.
This was so helpful, and I literally just came back from I was upstairs, I was late, I was doing a TBH USO where I was like, why are we taking the right ovary, for the, like, it's just really fun to hear someone say exactly the same thing I always tell everybody. But my question, I'm actually, so, with the standards of care 8, and this was, again, this literally just happened, I had to delay this case to this morning because we still have to get 2 letters for a lot of our patients. Because people have not adopted the standards of care. And so one of the things about
third floor,
the
hospital,
FCC is
all
that,
clear,
just because an organization
third floor,
recommends, you
hospital,
only need 1 letter.
all clear,
And just
Cold
clear,
Peak,
insurance
third
companies
floor,
don't adopt that, right?
hospital,
And so insurance
all
companies
clear.
actually usually follow, kind of insurance companies, because again, in this system, follow NCG Health, these kind of external third-party guidelines. I actually worked with them on their guidelines to try to get SOC adopted, but it still hasn't happened yet. And so my question for you is just, in Kaiser, how easy is it for you to be able to adopt something like that? Because you guys then can just say, we're going to adopt SOC, and just to be clear, in like an insurance-based system, we can't do that. And it can be really confusing for the patients because they know that SOC is out there, but they come to us and we have to still jump through a lot of things for them. And it's not just any 2 providers. Like sometimes it'll be any 2. This one I had to cancel because it had to be 2 mental health providers. It couldn't be a PCP. And then I've even had them say it can't just be any 2 mental health. It has to be an MD level mental health provider and then a mid-level. Like if I got like 2, so it's a really different system. And so just it's kind of a comment, but also a question for how you guys are able to really integrate those things into your system. What are the steps or layers to make this more accessible?
So, so just to sort of repeat, the question was, how easy is it for us to modify and adopt the SOC8 within Kaiser? And then a comment on how very difficult it is going outside Kaiser, getting approval from insurance companies. My short answer is going back to how I said, I never have to ask an insurance company to approve anything I do. When the SOC8 came out, like, boom, we just did that. And when we previously were requiring that there be any letters, right? So that letter would be something that would just be put into the patient's chart when they went through the consult in order to then be referred to our surgical center of excellence. Everything is just so easy. But I appreciate that just because the WPATH put out the SOC 8, that does not mean everything around the world changes immediately. Things do change slowly to some extent, not in this, but I think in general in healthcare, you never want to be the first or the last to do something new. And I think that I appreciate why that's the case. Unfortunately, when it comes to approving this sort of care, there are a lot of barriers that have been created, both well-intentioned and not. And the insurance companies are going to try and utilize those for their own purposes when they can. So the SOC 8 just came out a couple of years ago, continuing to push that. And as what is acceptable gets changed, hopefully we'll see the same changes in the insurance approvals. Yes.
Thank you. That was awesome. Coordinate.
Yes. So first of all, generally our patients are referred from one of the multi-specialty, like subspecialty clinics from around the region. At that place, they would have received counseling, usually from a mental health professional, on what our surgeries entail. So they've already gotten a description pretty detailed about what the surgery is. And then they will get, including risks of complications, et cetera. And then they'll get also like that thorough assessment I was talking about in terms of their social supports and their mental health, and they're getting care for all of those things there. Then they'll get referred to our surgery clinic. So that's here in San Francisco. At that site, we have the plastic surgeon who does the urethral lengthenings for our metoidioplasties and phalloplasties, also creates the flaps, really does make most of the external surgeries. I'm going to be there to talk to them about the vaginectomies and sometimes talk about hysterectomies. We also have one primary gynecologist on the team who does most of the hysterectomies. Although we actually, if she's not available, we'll just pull in one of the other gynecologists if indicated in order to have somebody else on the team there. In addition, so now I'm going to talk about how big this team is. We also have a urologist, well, 2 urologists now, who primarily manage the post-operative urethral reconstructions if needed. They also are involved in other things like gonadectomies, the implants, such as the testicular implants and the penile implants. They're also there in that clinic. We're not necessarily there at the same time, but it's very easy for us to communicate. And then there's one surgery scheduler who's coordinating all of this. So in order to get, for instance, last Monday, the gynecologist, me, and the plastic surgeon were all in the same operating room all day long last Monday. And that's her job to coordinate. The next day, we did a stage 2 phalloplasty. So I was there. I do some of the stage 2 phalloplasty work, like dissecting the nerve off of the clitoris and placing a suprapubic catheter if it's indicated. Excuse me. And then a couple of plastic surgeons also being in there in order to do the flap surgery. So having one surgery scheduler, I think, is really key. That helps us do that. In addition, at that clinic, there's the social worker who is involved in making sure that these patients have all of the supports that they need. And that is very complicated. I have tremendous respect for the work that she's doing for them. And then, of course, multiple nurses and MAs who are there to provide the care that the patients need. Did that answer your question about the coordination there? Good. Yeah.
go ahead. So, so I'm a general gynecologist. I do a lot of vaginal surgery, and I'm really curious about this vaginectomy issue where people, it seems like the mucosa is growing back, and why are people getting these masses? And I'm wondering, because this is similar to precautions, how does the literature compare? Does this happen in precautions patients as well? What do you think is going on, and are there surgical techniques or things that people have thought of to try to prevent the recurrence or redevelopment in these masses?
So first of all, I'm actually not aware of any reports in colpocysis of vaginal. Okay, good. I was about to say, I looked up vaginal remnant and found very little. Yeah, like you would like there's the channels, etc. Yeah. So I guess I could say, well, hey, maybe there are vaginal remnants regrowing in colpocyses. We just don't know about it because that's not symptomatic for those patients. The only really strong opinion that I have heard is that fulguration does not adequately remove the layers of the vaginal epithelium that need to be removed. Besides that, and again, reading that article by that team that's done over 300, and they've had a few of their patients come back with vaginal remnants, they're very clear. We don't know why this happened, although clearly it did. Reporting, which I thought was excellent, is exactly how I feel about it. I look at the patients, and I've had a couple come back where they've had vaginal remnants, and all I can say is, clearly this is what happened. I have no idea why. I was going to go into a more subtle thing, is that when I first started doing these, I was very wary of placing sutures directly underneath the urethra. And we wouldn't get exactly a vaginal remnant syndrome so much as we would see a lot of where there was the connection between the native and the neo-urethra, this little pocket that would kind of form, and it wouldn't become a fistula, but it was, I would look at that and go like, that's going into the space I wanted to close. After, the first 20 or 30 of these, I really feel like I'm obviously going to be putting sutures right underneath that urethra. I have to close that space and make sure that doesn't happen. So that said, I don't think any of those ended up being the patients that came back with the vaginal remnants.
Within urogynecology, I feel like it's sort of like a hot topic of like fellowship or not fellowship. And then I do think there are some generalists or people graduating who might want to consider fellowship. And so just, do you think fellowship is required, and how should these fellowships look to make sure that we're really getting adequately trained surgeons?
Yeah, I definitely think additional training to OBGYN is required. I think that what I learned in my urogynecology fellowship set me up very well to perform the parts of the surgeries that I do. But it certainly did not teach me to do the things that the plastic surgeons are doing, or anything in terms of vaginoplasties, although I know urogynecologists who have gone that direction with their training and gotten extra training in order to do it. There are fellowships being developed. Certainly, I'm sure you're aware of them. And I think from what I can understand, they some of them have more focused goals, and some are broader goals in terms of what they expect people coming out of the fellowship to know how to do. Again, to one in particular, I'm thinking of they expected people to come out of it being able to do vaginoplasties, but really not any of the masculinizing surgeries that I do. I think that particular fellowship I'm thinking of is probably going to change because of people moving around. But overall, I think right now there is nothing set, and what will need to happen is development of more than a year long of training in order to be able to provide all of the gender-affirming care. I really think a lot, you've heard me comment about what I found when I was trying to find the evidence for this lecture. I really think about where we were in urogynecology 25 years ago, where I would go to meetings and people would stand up and say like, I did 100 of these and that's the way. And that was literally OGS. And now if you did that at OGS, they would laugh you off the stage. That's not acceptable. But that is kind of where we still are right now with these gender affirming surgeries.
I think that's tough. So thank you so much.